which just change. So, I think in the beginning of the Mpox outbreak, this was something that, we all saw quite a bit and thought about quite a bit. And then more recently has, kind of quieted down. But I think that there's certainly been a resurgence and uptick in cases. So something worth discussing again. Also, we recently published a case that we saw here at Mount Sinai Hospital last fall. So I'm going to go over some of what's out there in terms of AST guidance, which is pretty minimal. And then a case series that was recently published in AJT, and then dive more deeply into the case that we saw here. So, okay. So this is just kind of numbers as of January 11th. So about a week or so ago. And so in the total cases in the 2022 to 23 outbreak in the US is 31,689 with 56 deaths overall in the US. Globally, much higher, 92,500 cases. But if you go to like the New York State DOH website, in the last year, there's been 195 cases in New York City of people who have tested positive for Mpox, and 26 cases in the last month alone. So I think we're certainly seeing a rise in cases. This is from the AST website and the guidance that they put out. And I think it's worth noting that it hasn't been updated since August 4th, 2022. But this is specifically focused on post-exposure prophylaxis and pre-exposure prophylaxis. And I think some of the guidance that is out there, and certainly some of the cases that are out there, are from a time when the vaccine supply was, kind of up and down. So this might have changed since, but they say, the AST says that post-exposure prophylaxis is recommended to someone with known or suspected high-risk exposure to any infected blood, body fluids, or close skin contact with an infected person. And they define high-risk exposure as unprotected contact with infected skin, mucous membranes, fluid, or blood, unprotected contact with contaminated materials like utensils, clothing, bedding, and then unmasked face-to-face exposure to an infected person within 6 feet for 3 hours or longer, or exposure to a patient within 6 feet of a procedure that may cause oral secretions and aerosolized secretions. And then there was also expanded post-exposure prophylaxis. And so, that's really based on the vaccine supply. But if there's enough vaccine, then it can expand to high-risk persons with high potential for exposure that maybe don't fall into those categories. For pre-exposure prophylaxis, so for vaccination, this is recommended for high-risk groups such as laboratory personnel working directly with Mpox, and then healthcare workers caring for or likely to be exposed to patients with Mpox. And then they say that this will expand based on the vaccine supply. And this will become more relevant to the case that we saw here that I'll go into. But if somebody doesn't necessarily fall into any of those categories, and they don't have high-risk exposures or high-risk behaviors on their own, what if a transplant patient is living with someone or caring for someone with probable or confirmed Mpox? What should they do? And so AST says that transplant patients who are household members of someone with Mpox should avoid contact with them until the rash has resolved and the skin has re-epithelialized. That they should not share anything that could be potentially contaminated, and that the infected patient should isolate and avoid contact with the other household members, and they should cover all skin lesions. and that the transplant recipient should discuss with their provider if they're eligible for treatment or post-exposure prophylaxis. And that they may benefit from it. And then there's also some guidance on AST about, the question of potential donor-derived infections. And I think, again, that this was something that was kind of discussed a lot in, the early stages of the outbreak, but maybe is certainly not something that I've thought about recently. But, the donor-derived infection is theoretically possible since Mpox is transmitted via body fluids. So certainly, you would imagine an organ could potentially transmit the infection. So the recommendation is that a pre-procurement evaluation of both living and deceased donors should include questions to assess risk of Mpox exposure or active infection, and then a physical exam for skin lesions. And then anyone who's been recently exposed, the recommendation is to defer donation for 21 days, and that's because the incubation period is so long. And then also recipients who have been exposed through transplantation, it was recommended that they can receive TPOXX or tecovirimat for post-exposure prophylaxis. But, as far as I could tell when looking through the literature, to date, there's been no evidence, no cases of donor-derived Mpox infection. So this was a case series that was published in AJT in December, multi-center that included a bunch of centers, including ours, where they gathered, Mpox cases and solid organ transplant. Aside from this case series, most of what's out there is, a couple of single patient case reports. So in this series, they included 11 cases from 7 centers of confirmed Mpox in solid organ transplant, and it was from July 22 to February 23. So you can see this is the table of their demographics. Couple of interesting things to point out. All of the patients were men. And 10 of the 11 patients included were kidney transplant. The other one was liver transplant. 7 of the 11 patients did have HIV. All of it actually was well-controlled HIV. The median CD4 was 632. And the range was 267 to 1487. And then they, in terms of like the exposure to Mpox, 5 of the patients were exposed to Mpox through sexual contact, 3 through non-sexual close contact, and 3 were unknown. They also asked about Mpox vaccination status. And again, some of this was like before vaccine was more readily available. And only one patient had received 1 dose of the Mpox vaccine, but there were 2 patients who had received smallpox vaccination in childhood. And all of these 11 patients were treated with TPOXX. So 8 of the patients, or 73%, had disseminated disease, which they defined as, greater than 20 skin lesions. 1 patient, which is the patient I'm going to discuss, did have pneumonitis and shock. 1 patient had a secondary bacterial infection. 1 patient had persistent peritonitis. And there were 2 cases where they had CMV reactivation co-infection. But of all of the cases of the 11 patients, 10 of them did have clinical resolution. And 1 patient, there was 1 death in the series. So for the most part, it seems like the patients did okay. So I wanted to spend the bulk of the time going over this case, interesting case that we saw at Mount Sinai Hospital.
Risa, before
yes.
we go to, someone in the chat is asking,
oh, sorry.
Table 1, why tobacco use was included.
I'm not sure actually. I don't know if they stated specifically in the paper why they asked that question. I don't know. But we can go back and take a look. It was in this December AJT. Or maybe someone who was involved on this Zoom might know. We could see.
Yeah, we can look into it after.
I was involved with this paper, but I can't recall why we decided to include smoking status, so I can go back and look too.
Thanks. Okay, so this was a case, this was the first case in the literature of rapidly fatal Mpox infection. And it was in a kidney transplant recipient through secondary household contact. So, and this was October 2022. So our patient was 53-year-old Black man. He had a medical history of hypertension and end-stage renal disease. And he had a deceased donor kidney transplant in the spring of 2022. So about 6 months prior to this presentation. In terms of his transplant course, at the time of transplant, he got induction with 3 doses of ATG and methylprednisolone, and then he was discharged on tacrolimus 11 milligrams BID and MMF 1,000 milligrams BID. Early post-transplant course was complicated by delayed graft function. He also had a UTI with secondary bacteremia, and he had BK viremia that peaked at 229,000. And 5 months post-transplant, a little bit before he presented to us, he was admitted with CMV viremia. He was donor positive, recipient positive, and then he also had acute cellular rejection, and he got another round of increased immune suppression with IV methylpred and ATG 2 mg per kg for 3 days. And so this is a timeline of his 3-day hospitalization at the time of this presentation. So he came in October 2022. At that time, he was reporting to us about 4 days of bilateral flank pain. That was his reason for presentation to the emergency room. And when he came in, he had a white count of 46.7, a hemoglobin of 9.8. His platelets were 26. And this was all, of course, not consistent with his most recent baseline labs. He had a mild transaminitis with an AST of 185, an ALT of 96. Notably, his bilirubin was normal. He had a very high LDH at 3,396, an elevated INR, and an elevated D-dimer. Pretty quickly after he presented to the emergency room, he developed hematemesis, and so he was admitted in our transplant ICU, and they started him empirically on vancomycin and cefepime. They then noted that he had this diffuse nodular umbilicated rash that was across his face, chest, abdomen, and upper extremities. And I'll show a picture of that in a minute. And so at that point, they called transplant ID to come and see him. When we saw him, we felt like the lesions looked consistent with Mpox, and so sent the in-house testing for Mpox PCR swab on one of the lesions on his back, and then started him empirically on TPOX 200 milligrams every 12 hours. When we talked to him further about this, it turned out that he had been caring for his son the timeline was a little bit unclear, but it sounded like he had been living with and caring for his son for a matter of weeks. And his son had developed a similar rash and was recently started on medication for it as an outpatient. His son did have HIV. The patient told us that he was sexually active only with his wife and did not have any recent sexual encounters or recent exposure to anyone with any similar rash aside from the son that he was living with. We started him on TPOXX on hospital day 2. Other notable lab findings were that he had some BK viremia with a level of 12,000. He had CMV viremia with a level of 9,660, and he had negative blood cultures. On the 3rd hospital day, the swab resulted positive detected for Mpox. But his clinical condition continued to worsen. And he pretty much, developed multiple complications. He had lactic acidosis, multi-organ failure, anuric renal failure, severe coagulopathy, liver dysfunction, and shock, and was started on 3 pressors. He also developed acute hypoxic respiratory failure and was intubated. We continued him on empiric antibiotics, of course, and then he was also started on stress dose steroids. His lactate peaked at 11.9, his INR at 6.6, and he continued to have worsening LFT abnormalities with an AST of over 1,000, an ALT of about 700. But his T-bilia again stayed relatively normal at 1.6. It was at this time that we had a consultation with the CDC, and they recommended adding a dose of cidofovir, which we gave him 5 mg per kg times 1 on hospital day 3. And then there was also a plan to give him vaccinia immune globulin the next day. But unfortunately, a little while after we added the cidofovir, he had severe bradycardia and then a PEA arrest and had, ACLS and CPR, but expired soon after in the evening. So this is some of the autopsy findings. We were able to work with the New York City medical examiner who helped with a lot of the path findings, the gross and then also the microscopic findings. So some of that was included in the case report. I can go through that as well. So the top picture is just of the patient and his rash. And, based on what we saw, we felt like the rash had probably been around for some time, probably weeks, because a lot of the lesions look kind of older. But he did have this diffuse nodular rash, and it was really across his face, chest, and upper extremities, much less so on his lower extremities. I forgot to mention when he got to the transplant ICU with hematemesis, GI did do an EGD. And they said in their report that they saw vascular appearing raised purple blebs with oozing and bleeding in the entire esophagus. And they told us that they felt like it even looked like Kaposi's sarcoma, like it was that type of like purple raised lesion. And you can see here, so this C is the esophagus, and there's some of those raised lesions in there. And then D is the hypopharynx and a couple of these big nodular raised lesions. So these are some of the path findings. So definitely not a pathologist, but I'm going to share with you kind of some of the what was explained to me and some of the more notable findings. So A here is of one of the vesicular lesions that was found on the patient's skin. So this is from the rash on the skin. And the notable findings there were ballooning, degeneration of keratinocytes, and then mixed inflammatory infiltrate. So nothing super specific to Mpox. B was a keratinocyte that showed a lot of, and they said an overwhelming number of mature and immature virions. So these lesions in the skin were just completely packed with viral particles. C is the hypopharynx, so the one on the previous slide that had all of those really big nodular lesions. And similar to the skin lesions, it again showed that ballooning degeneration of keratinocytes, and then also a lot of acute inflammation, necrosis, and hemorrhage. D here includes is an ultrastructural snapshot of the hypopharynx, which shows the viral assembly sites. And then oh, my mouse is gone. This little thing here is a virion that was zoomed in. This was path from the esophagus, which just showed a lot of mucosal ulceration. And then F is the liver, and there was hepatocyte necrosis, and then also throughout the liver, intracytoplasmic inclusions. And so that's something that really hadn't been previously reported, viral particles in the liver itself. And so overall, all of these findings, there was a lot of necrosis, hemorrhage, and tons of viral inclusions. They did also, this isn't shown specifically here, but the pathologist did orthopox virus immune staining that actually was performed by the CDC. And they tested, every single tissue from the patient, including skin, esophagus, lungs, liver, spleen, lymph nodes, kidneys, and testes, and every single tissue stained positive for orthopox virus or Mpox. So it was found in every single tissue. So, I think that this was a surprising and, of course, very interesting case. It was really the only time that we found in the literature of somebody having such a fatal course from Mpox, and where, every single thing was really attributable to the Mpox. There were no other secondary infections found, no bacteremia. And while there was some viral reactivation of, BK and CMV and stuff, I think that was, we all felt that was more so related to the patient's degree of immune suppression, as opposed to the driving force of any of the patient's multi-organ failure. And the pathologist did also note that when she stained the different tissue, all of the stains for the other viruses like CMV were negative. So none of that was in, the liver either. But I think aside from that, the other important thing that came out of this case was really the need for expanded vaccination efforts. And for potentially thinking about these populations that are maybe not classically at risk for Mpox, or we wouldn't think would be at risk for Mpox infection. He wasn't MSM, he didn't have HIV, but he definitely had risk factors, and had he been vaccinated, his outcome hopefully would have been different. So, this is the current New York State vaccination guidance, which is similar to what I showed in the beginning, but really just includes the patient populations that we think for as having classical risk factors for Mpox or sexually transmitted infections in general. And I think in our population, when we have these patients who are severely immune compromised, and he was also definitely severely immune suppressed with his recent treatment for rejection, it might be, it's probably worth taking more time to really dive into the history and ask more about potential exposures beyond just sexual exposure, but, you know, household contacts, I think, was a really big one in this case. So, you know, definitely a lot to think about and a lot to learn there. And with this resurgence in Mpox cases, maybe thinking about vaccinating a broader population. That's all I have. If anyone has any questions about
Thank
the
you.
case.
Someone asked in the chat, how this, I'm referring, I think it's referring to the pathology, how it might compare to other viruses, other pox viruses or smallpox. Is it similar pathology?
I believe so, yeah. I think it was ortho, like are you talking about?
I meant like, you know, like all the viruses in every tissue, like they found, and all those pathologic changes in every tissue that you described. Like, is that how much, what would be seen in smallpox? Like, I have no idea. I was just curious because we don't have any other real pox viruses that we see
Mhm.
very often. So I was just curious how that compares, but it's okay if you don't know.
I mean, my impression is that like the cytopathic changes are pretty consistent against like the orthopox viruses, but I think that the degree of hemorrhage and necrosis, and then also like just the overwhelming amount of viral particles was much more specific to this case, and also like not really specific to Mpox in general, because this is really the only case that I know of that's been reported like this. And I think that has to do mostly with how immune suppressed he was.
Thanks.
And I think what I remember from our discussions of this case, Risa, is that the social, like household history wasn't really known to the transplant team, right? Like they did not
Right.
know that he had a son who was HIV positive and hence potentially at risk. And because he had the lesions going on for some weeks, but I don't remember if he ever reported it to the transplant team before it just got really, really bad and he came into the hospital.
He didn't. No one knew, and part of that's because he didn't report it, and part of it's because no one asked. But I think the idea of asking our patients, like, you know, oh, maybe you don't have risk factors for Mpox, but does anyone that you're, you know, spend a lot of time with
Yeah.
and that you take care for have risk factors, is not something that we typically do.
Yeah.
And maybe something that we should think about more.
And you mentioned pneumonitis, like, I mean, not that I doubt it, like, but was it seen in the autopsy as well?
So he had hypoxic respiratory failure from multi-organ failure.
Yeah.
And they did see, I believe they saw Mpox in the lung tissues. Just see what they
Yeah,
said.
not surprising, like, but yeah, I was just curious. Like,
Yeah,
if
they
if
saw
the pneumonitis.
the immunostaining was positive in the lung as well.
Thank you. Does anyone else have questions for a speaker?
I think there is a question, the FICA you wanted to go back to, okay, got it,
Yeah, I
okay,
saw
just the
the
pictures.
Oh, here it is.
If they had additional pictures, I just wanted
Yeah.
to see how it looked when he first came in, but I guess this is it. Thank you.
And-
Yeah,
and
you know,
is it possible? Oh, sorry, go ahead.
I was just gonna say it looked like pretty burnt out, honestly. Like it, you know, he told us it hadn't been there for very long, that it was new, but it looked to us like it was, you know, probably had been there for a few weeks already. Hard to say.
And is he, I'm sorry, what was I gonna say? Is it possible to check like a Mpox like PCR on the blood? Is that something that's available, or is it really just on the lesions and other material?
It's
So
actually
we-
available in carriers, right? We've had a couple of
Ah,
with
okay.
just carriers.
Interesting.
Embarrassing
it.
enough to our dermatology team, but yeah.
So our like molecular lab, Alberto did do that. And included calculated like the cycle threshold as to how like the Mpox PCR in the blood changed over time through the hospital stay. I didn't include that in this, but I have that information if anyone is interested. It was like something that was done kind of offline. They also did do, he did whole genome sequencing to see if there was any like genomic variation over time or of the virus in different parts of the body, and it was all exactly the same.
Yeah,
I
and
would guess that the CT values were very low, right? And I'm sorry I had to step out for 5 minutes, but I'm sure you mentioned this, that by every means, this was a high level of inoculation, right? And his sort of viral burden was probably incredibly high, judging by sort of the length of exposure to the household.
Yeah, so it was an ongoing exposure. It wasn't, yeah, that was the other part of it. Thanks for bringing that up. It was, he was still caring for the family member, so it wasn't like, you know, a sexual encounter that then
Right.
was separated. It was a persistent exposure.
And my memory is that his son had a very severe case, right? It was like the son himself probably had a very high viral burden.
Yes, yes. And I think like at the time that this was all going on, the son was still well enough at home, but later ended up having complications and hospitalizations. But yeah.
well, thank you for that interesting case. You know, I think what's interesting is that he didn't have the risk factors, so we have to keep our, you know, our differential open. With the rest of the time we had, I just wanted to go over the schedule and our plans for the rest of the year. I'm gonna share my screen really quickly. Can you all see my screen? Yes.
Yep.
Okay. So this is our, you know, this is our first meeting in a while, so thank you all for coming. Thank you to Sarah and to Risa for presenting. So today was our SOT subgroup meeting. In February, ASTCT is happening. If there's enough people who are going to that and are interested, we can try to schedule an in-person meetup. I don't know if people have thoughts or feelings about that. And then in March is going to be our next, you know, Zoom meeting where the HEMONC subgroup is going to present. I think they're going to do a case or that or overview of the ASTCT meeting. I don't know if Peggy or Sam are here to comment, but our next meeting will be in March. And then in May, we'll have a diagnostics or PEDS meeting. And then ATC will be in June, and we'll schedule a happy hour and meetup during that meeting. And then we'll take a break for July, and we hope to restart again in August or September of 2024. We're also looking for volunteers. So, you know, these are the current leadership for the different subgroups and for North East Transplant ID in general. But if you're interested in getting more involved or leading one of these subgroups, please let us know. You can reach out to me or Maricar, and we can put you in touch with people. But we're hoping to get some more people involved. And it can be a junior, senior person. We're not going to leave you by yourself. We'll pair you, if it's a junior person, we'll pair you with the senior person. So please feel free to reach out to me and try to get involved. And I know Maricar is also, you know, TTS is also looking for cases for the CPC webinars. So if you have interesting cases that you think will be good, let Maricar know. And with that, I just want to open it up. If anyone has anything they want to say, or, you know, I want to open it up to anyone for questions, comments, anything else.
Hi, I was just going to say for the HEMONC meeting in March, we haven't set the date yet, but we're looking for another volunteer if anyone is going to ASTCT. If anyone would like to just go over any noteworthy things that they see there in like 20 minutes or so for the next meeting, that would be great. Or if you have an interesting case and you'd like to do that, that would be good too. So just send an email to Samantha or myself. Thanks.
And I don't know if we can just get a poll of hands. Are people going to ASTCT? Should we schedule an in-person meetup there, or if there's not enough people, we won't schedule? Sounds like that's probably a no. But we'll schedule something for ATC. Yeah. Anything else? If not, thank you guys for joining, and we'll hopefully see you in March.
Thank you so
Leanne.
much.
Thank you, everyone.
Thank you.
Bye, thanks.
Thanks. Thank you.